Okay, so care in the home involves care that's in the patient's own home or the relatives, nursing home, homeless shelters, group homes and hostels, prison and other institutions. And the models of care and terminology vary with respect to location and the health system you're dealing with. And is characterized by symptom management and supportive caregivers. If you think about how home care developed, in the 70s and 80s, patients had a very long length of stay relative to now in the hospital. The decision to discharge was based in some part on the patient and family preference. By the 90s, long hospital stays were replaced by early discharges and a shift of the care to the home. So then we started giving IV antibiotics in the home. It wasn't uncommon for a patient with SBE back in the 70s to spend weeks in the hospitals on IV antibiotics. So there was really a diminished patient or family choice in the matter of where the care was going to be given. So home care staff and families now manage very complex medical care. And so the question is more and more things will be done in the home. So the benefit of home care is that there's the potential for improving the physical comfort of the patient, the psychological comfort certainly. It can promote healing of relationships, and particularly important in end-of-life care. And the family shares the transition from life to death in hospice home care. It's important to successful home care to look at what the needs of the caregiver are. Obviously, we want to palliate suffering via pain and symptom management and spiritual and emotional suffering. We want to prepare the family and caregivers somewhat for emergencies and anticipate that there may be an urgent situation in certain diagnoses and warn them about it and go through a plan. And then there's a matter of what equipment you need to provide successful home care. Home care outcomes can be measured by the effects on family members following the death of the patient, and we'll show you a study of that a little later. Positive experience with home care can result in positive bereavement and adaptation by the family members after the death. So the question is, are patients really more comfortable at home? We have a lot of patients on 4 carpets, you know. So let's look at whether it's, in some cases, it's really better to have the patient at home. Look at what the problems and the needs of the end-of-life caregivers are and what makes palliative home care successful. With respect to death in the home, most patients don't achieve their wish to die at home. In the U.S., out of 2.5 million deaths annually, about 75% of patients die in an institution, and 61% in hospitals and 17% in nursing facilities. In the UK, 55% of cancer patients who wish to die at home, only 23% of them do. The older you are, the more likely you are to die in an institution. In Italy, in a community palliative care service, they managed to keep 75% of their patients at home. That was quite a while ago, that study. And in Sweden, only 37% are dying at home. In Western Europe and the US, the rate of home deaths are steadily decreasing. Factors determining the place of death varies by region. In the UK, patients who wished to die at home were those who expressed a preference to do so, were aware of their imminent death, and had lived with their caretaker a while. They also tended to be patients who had solid tumors, whereas it was more common for patients with non-solid tumors, such as leukemias, to die in the hospital, or patients that had more than one illness, a number of comorbidities. So home deaths depend on the role and the influence of the general practitioner, the private doctor, what the situation with relatives and friends are, availability of medications, equipment, and handling of emergencies. And patients who die at home tend to be married, less depressed and anxious, and well supported. So, as I said before, in the UK, the percentage of home deaths in 1994 was 27%, whereas by 2003 it was 22%. And deaths at home seem to be decreasing even if there's a community palliative care service. The palliative care service is of a high standard, and specialist palliative care advice is available around the clock. So I find that interesting. So looking at are patients more comfortable at home, there's a couple of studies I want to call your attention to. In Journal Pain and Symptom Management in 2003, there was a prospective study of 60 unresponsive dying patients. The relatives and the nurses evaluated the patient's discomfort, behaviors, and the reasons suspected for the patient's discomfort. Okay, so they had the nurses doing it, they had the relative, the caregiver doing it. And the relatives reported more observed behaviors and associated pain as a reason for the discomfort more frequently than the nurses did. So whatever behavior or discomfort they were observing, the relatives tend to attribute it to pain more frequently than the nurses did. In 2002, there was a study that described the difficulties patients had with pain management at home. Okay, sometimes it can be a very big problem. One of the problems was obtaining medication. Now, one of the advantages of being on hospice, if you're appropriate for that, is that you get an emergency box with opiates and all sorts of things to deal with emergencies. And hopefully the medications that you need come within a few hours of your admission to hospice. If you're a palliative care patient or just a regular patient, you can go out to Brooklyn and bring your prescription to Roxanol to the pharmacy and it's not there. We don't have it, or we can order it, but how long is that going to take? 2 days, 3 days? So it can be a very big problem. Accessing information was identified as a big problem for patients with home care. Tailoring regimens to meet the individual patient need, managing side effects, processing of information that was given, managing new or unusual pain, and managing multiple symptoms simultaneously. So these are the things that were described as difficulties for patients at home. So what the conclusion was that information about cancer pain is not sufficient to adequately control pain in the home setting. That is, when the patient is signed on to home care, they don't really have enough information to manage pain successfully, and that they require ongoing assistance to solve problems. Certainly, another advantage of hospice is the 24-hour on-call line, so that new symptoms come up, pain changes, and it happens generally at odd hours. So you really need that 24-hour number. One of the disadvantages of Met Jewish palliative care service is they don't have a 24-hour number to call. So if you have a patient on palliative care rather than hospice because of nursing hours, they don't have a number to call at midnight when pain suddenly flares up and is out of control. Hi?
Oh, you cannot use the hotline number?
Not for palliative care. For hospice, yes.
I thought it was the same, no? Okay.
No, they don't. It's a different staff. It's a different team that takes care of it. So it's a very, very different service. They'll take the call and pick up the phone the following morning. If that happens to be a Saturday or Sunday, it may be a little bit of a problem. So and that's specifically to our palliative care home service. There may be, I don't know, do you know of palliative care home services that have 24-hour phone coverage? It's one of the advantages of being on hospice if it's appropriate. At least there's a number to call. A qualitative study in 2002 looked at the factors associated with meaning spouses ascribed to the experience of pain during palliative care services. They described two states, the in pain and out of pain state. Spouses described helplessness, fear, and unfairness when the patient was in pain. And once the pain was controlled, described a more peaceful, relaxing feeling, returning to the old routine and focusing on the future consequences. And you know what they decided when they looked at this was that pain state, the spouses were thinking about the patient's mortality more often than the patients were. So once the pain was over, they could concentrate more on future consequences. So what problems and needs do end-of-life caregivers have? They have to solve new practical problems. They have to deal with the patient's sorrow. They have to deal with their own sorrow. The experience of symptoms that the caregiver experiences was looked at in 2008. There was a review of the literature from 1990 to 2007. And most of these studies that they looked at depressive symptoms in caregivers. They were the most numerous studies that were out there. There were very limited studies on caregiver anxiety, sleep problems, fatigue, pain experienced by caregivers. So little is really known about the prevalence and effects of symptoms in caregivers. In the Journal of Clinical Oncology, they looked at family caregivers and found that a high percentage of caregivers had a variety of symptoms, and some of them were at a clinically meaningful level. Obviously, if the primary caregiver is experiencing depression, anxiety, sleep problems, that has a negative impact on the caregiver's functional status and the quality of the life. There was a literature review of 94 papers of the relative situation and needs in end-of-life care. And what was determined from looking at all these papers, what was most important in terms of the impact of the caregiver's situation was that they felt that the patient was getting good care, the ability to be there or be present, communication with the medical team, sufficient information or knowledge about what was going on, and felt that the attitude of the professional needed to be supportive and trusting. So this is what is most important to your primary caregivers. What about communication when the care is transitioned to palliative care or hospice? Most complaints from caregivers about home care relate to poor communication and insufficient information. That is, 51% of caregivers did not feel that they got sufficient clinical information, and only 28% found communication easy with their doctor. So in general, communication was described as poor between the patient and the doctor and the nurse, and any consultants that were called in, and the primary doctor. A variety of factors influence symptom management at home, and we need to anticipate problems that are frequent and common in palliative care and end-of-life care. This is the first thing here is the Italian study in which they managed to have 75% of their patients die at home. This was a community palliative care service. Pain seemed to be better controlled than other forms of suffering, and 25% of these patients were unconscious for the last 12 hours of life. Another study in 2002 showed that patients and caregivers felt that palliative care was less well provided in the home than in the palliative care unit and the hospitals. So that's interesting. We all know that when we have patients with symptoms completely out of control, we send them into the inpatient unit. In managing medications, we want to preserve comfort, diminish the family burden, and avoid complications and hospitalizations, hopefully. In order to do that, it's best to simplify the medication schedules, try to use a single agent if possible rather than multiple agents, and use simple routes and schedules to administer. So this is an A to Z list of frequent symptoms and complications of home-based palliative care. Ascites, anxiety, altered mental status, bleeding, blocked stents and catheters can occur. Confusion, constipation is often a reported problem. Shortness of breath, delirium, depression. One of the worrisome problems is always a patient who falls out of bed and gets a hip fracture and is a hospice patient, is end of life. What do you do with that? How do you keep that patient home? Hiccups we see with certain illnesses, lack of sleep, nausea, vomiting, fungating lesions that are malodorous, myoclonus from opiate toxicity, pain, and the two emergencies we should always be on the alert for are spinal cord compression and superior vena cava syndrome. This is a list of true medical emergencies that can occur in the home care patient. The patient who's acutely confused, combative, agitated, is difficult to manage at home. Blocked stents, we said before, convulsions. Anybody who has a brain tumor should have some benzodiazepine in the comfort box or as a prescription if it's a palliative care patient to deal with that. Intestinal obstructions, very difficult to manage at home for our patients who have malignant bowel obstruction. Hemorrhage, panic attacks, again, fractures can be very, very challenging to deal with at home. Pericardial pleural effusions, and again, cord compression and superior vena cava syndrome. The agitated patient, particularly in the elderly, one needs to think about urinary retention and fecal impaction. So patients who sign on to our hospice and get a care box or a comfort pack, and we usually tell them to put it in the refrigerator. Now, why do we do that? So that they know where it is when the emergency comes up. Most of these drugs don't have, I don't think any of the drugs actually have to be refrigerated. So patients worry about that. But the reason we tell them that is so everybody on the telephone, the nurses, when the call comes at 3 o'clock, can tell them, go to your refrigerator, because we know where it is. So what's in the comfort box? Immediate release opiates for pain and dyspnea, benzodiazepines for anxiety, seizures, and dyspnea. There's usually antiemetic suppository like prochlorperazine, anti-sialagogue, either hyoscine, I think in the Met Jewish box is atropine eye drops, which we use orally for secretions. Right. Neuroleptic should be in there, some haloperidol. Many of them have steroids, an emergency dose of steroids in case of cord compression or even for dyspnea and COPD, nausea, vomiting, and pain. And a lot of the boxes have diuretics. Some organizations will have particularly a pediatric box, a cardiac box, a seizure box, a neuro box, so that they'll vary the medications according to the diagnosis. So you can order boxes specific to the diagnosis, and they'll have a little bit different medications in them. Most of the time, if you look at a chapter on home care, this is what they go through, the equipment that you need for the home. On hospice, all of the durable medical equipment that relates to the terminal diagnosis is provided. For some patients, even a telephone, a bedside table may be a problem. Those of us who've done home care know that we go into some homes and the first thought is, how are they providing care? You know, there's no table, there's no telephone, the lighting is bad. So in general, you need a mattress and if the patient's, if it's appropriate, an anti-pressure sore mattress or pads, feeding cups, spoons, a medicine measuring cup or syringes, blankets, air fresheners, ice cubes, commode, a male urinal, a bedside table, a chair, a nightlight, and a telephone. Some of the patients we sign on to hospice don't have even some of the basics, so it's important to think about that when you go into the home. Multiculturalism is on the rise, so that we need to be aware and sensitive to the cultural differences in our patients and their extended families in some cases. There are language barriers. There are traditions that need to be respected. There are religious beliefs, particularly about end-of-life care and beliefs about death. And there are even beliefs about how pain and symptoms should be managed. Okay. So, does home care save costs? Well, it saves costs to the third-party payers. However, some of that cost may be given to the patients and their family. And home care can be significantly expensive in terms of lost wages that you need to stay home and take care of a very sick patient, medications that may not be covered by insurance in a patient who's not on hospice, custodial care, caregivers that need to be hired. So it can actually be quite expensive to take care of a patient at home. With respect to geriatric population, we know that the population of patients with multiple medical illness has been steadily increasing in patients more than 65 years of age. Elderly patients cared for at home have very special needs, and understand that their caregivers may be very elderly as well. The spouse may be very elderly. With respect to the home care of children, most literature is focused on adult patients. The home care of the ill child is very demanding, and parents of pediatric cancer patients generally report that a child's pain is inadequately treated. This is the Institute of Medicine report in 2003. There's inadequate assessment and treatment of pediatric pain, and that's consistent with what the literature still says about pediatric pain. Outcome of home care can be evaluated by its effects on the family, particularly following a death. There was a study reported in 2004 that looked at 1,500 deaths, and it was a mortality follow-back survey of family members who took care of the patient or were involved with the patient at the last place of their care before death. So the questions that were asked were, did healthcare workers provide physical comfort and emotional support? Was shared decision-making supported in end of life? Did they treat the dying patient with respect? Were the emotional needs of the family attended to? And was the care provided considered to be coordinated? This was reported in 2004 JAMA. So of those 1,500 patients, about 33% died at home. The rest died in assorted institutions. That was 519 patients. Almost 200 of those patients did not receive any kind of home nursing services. About 12% got home nursing services, and 49% of the 519 had home hospice. About 25% overall reported inadequate treatment for pain or shortness of breath. 25% reported concerns with MD communication. And 33% who died in a hospital or a nursing home reported that there was insufficient emotional support, whereas only 20% who were on hospice reported that there was insufficient emotional support.
This is national data, or it's just New York State?
National data. National. Sorry, I screwed this. He needs to bring me that.
49% home hospice. That's really high.
Well, no, it's not 49% home hospice. There were 1,574 patients. About 500 of them died at home, and 49% of the 500, so about 250 patients out of 1,500. Yeah, that would have been surprising, you're right. What about respectful treatment? This is something identified as extremely important. So the caregivers were asked, were the patient and families treated respectfully? If you were in a nursing home, about 68% reported they were treated with respect. In a hospital, about maybe 80%. And in home hospice, 96%. So if you want to be treated respectfully, go with hospice. The overall quality care was reported as excellent in about 70% of hospice patients and less than 50% in patients who died in an institution or home health service. The conclusion was that many people dying in institutions have unmet needs for symptom amelioration, physician communication, emotional support, and respectful treatment, and that family members of those receiving home hospice services report a more favorable dying experience. And that's all. A little bit of a short lecture, but this is on the drive if you need to look at anything or any of the studies. Thank you.
Thank you.